May I invite Dr. Tom Thomas, please?
A warm good afternoon all. I would like to thank organizers of Kasicon for giving me such a wonderful opportunity. So whenever think of an acute DVT, that first thing that comes to our mind is pulmonary embolism and mortality associated with it. That may be the reason why most of these patients are being sent to a medical specialty for the management. But there is a chronic sequelae of a proximal DVT known as post-thrombotic syndrome that can make both the life of the patient and surgeon very difficult. And that affects almost 50% of patients also. So we know our patients' legs better than anybody, any other specialty, right? So we should take a leading role in managing that. It's a preventable cause of mortality and morbidity. But end of study, Indian subset was showing there was a gross underutilization of pharmacoprophylaxis in India. So how can we know who is at risk for developing a DVT? There are many scoring systems. One of the most validated scoring system is a Caprini score. A chart like this is available, and I think it will be a good practice to calculate the score of these patients when they are getting admitted to a hospital. For an example, a 65-year-old male with CA rectum and we are planning for APR. His total score will be 6. So what prophylaxis will you give for that patient? So according to Boston University, this patient comes in high-risk group. He should give a mechanical and also pharmacological prophylaxis. And see, we have to give, in these cases, a thromboprophylaxis for a minimum of 7 days. If score is more than 9, especially in a hip arthroplasty, patient is at a high risk and we need to anticoagulate for 30 days. What is most of the time happening is when after a major surgery, when patient sits up and walk, we will stop their anticoagulation. But remember, a patient said to be properly ambulant, he should walk for 30 feet on his own and his calf muscles should work. Even if that risk is gone, there is other risk factors like age, malignancy, major surgery, etc. So we should give adequate prophylaxis. For diagnosing a DVT in a symptomatic patient, well score is good enough. If radiological investigations are getting delayed, we can even start anticoagulation in a patient with a well score more than 2. A whole leg duplex ultrasound is enough for most of the patient for management. But sometimes when thrombus extending proximal to the inguinal ligament, we need a CT venogram. And also in a young patient with left-sided DVT to rule out a Merth-Turner syndrome. So classification of DVT, I think this should be there in the discharge card of all of our patients. It's divided into proximal and distal. Distal means it is distal to the popliteal vein. And based on the probable etiology, it's when there is one or more provocative factors are there, it is provoked DVT. And it can be a major risk factor which is transient, or it can be a persistent factor like a malignancy or a collagen vascular disease. If we are not able to find out any provocating factors, we will consider it as unprovoked DVT. If an unprovoked DVT patient comes to you in old age group, we have to consider for an age-appropriate screening for malignancy because about 12% of them later turned out to have a malignancy. In younger patient, we can consider for a thrombophilia workup, but it has fallen out of favor in the recent guidelines. So these are the usually sent thrombophilia workup, but that costs about 25 to 30,000 rupees to the patient. So when will you send the sample? Never during an episode of acute DVT and while patient is on anticoagulation. The best approach will be to give anticoagulation to this patient and for the 3 months and then the sample. After stopping the anticoagulation, send the sample. General treatment is start anticoagulation as early as possible, give a good limb elevation. There is no need for strict blood test after starting anticoagulation, give good hydration, and compression garments can be given to relieve edema. So anticoagulation therapy is the cornerstone in the management. The standard conventional treatment was to give a parenteral heparin followed by vitamin A and maintain an INR of 1 to 2. But with the introduction of DOVAX or direct oral acting anticoagulant, which acts directly on factor 10 and 2, this revolutionized the management of DVT. It was introduced in 2009 with the dabigatran, then came the rivaroxaban. Advantages are it can be given orally, it's having rapid action. So there is no need for bridging with a parenteral heparin. And it is having reliable pharmacology. So there is no need for monitoring. And also the chances of major and minor bleeding are less in a case of DAVAC. So currently the drug of choice by ACCP guideline is DAVAC in a patient with normal renal and liver function. The concerns were of availability of antidote and cost. But cost effectiveness of DAVAC, even though warfarin is very cheap, this patient needs to undergo a frequent PT-INR monitoring and he needs to come hospital, and there is concern of loss of wages also. This was proven in a US-based study in which you can see even after considering all the risk factors, bleeding, everything, the total medical cost was less in a patient treated with DAVAC. So how long will you treat this patient? If a DVT is diagnosed, the minimum treatment duration is 3 months. At 3 months, after 3 months of anticoagulation, we have to decide whether to stop anticoagulation or continue anticoagulation for secondary prevention. Here we have to we have to balance the risk for a recurrence for DVT and chances of bleeding from an anticoagulation. Segment-wise, distal DVT, you can keep the patient under surveillance or treat if there is persistent risk factor like a COVID-19 infection is there. For femoropopliteal DVT, they usually do well with anticoagulation alone. In iliofemoral DVT, these are the most symptomatic form. Post-thrombotic syndrome is high. So considered for an early thrombus extraction using a catheter-directed thrombolysis or thrombectomy. This was shown to have a mild to moderate reduction in post-thrombotic syndrome, even though there is no advantage on overall survival. Then IVC filter. The only indication for putting an IVC filter is when the patient is having a contraindication to anticoagulation. Otherwise, we should not put IVC filter into these patients. So AOP-basis treatment is feasible with the introduction of DAVACs. And the recent guidelines recommend for a provoked DVT, we have to give 3 months, preferred drug is DAVACs. In unprovoked DVT, we have to give extended therapy with not scheduled stop. But as I said, we have to balance the risk of DVT recurrence and the bleeding chances. In a patient with active cancer, previously guidelines were preferring LMWH, but latest guideline preferring DAVAC also, with a special caution in patient with luminal and genitourinary malignancy. In patient with APLA positive patient, we have to give extended therapy. The preferred drug is vitamin K antagonist after an initial heparin bridging. So summarizing, it is VT is not uncommon, prevention is better than cure, DAVACs as the first line of agent, OP treatment of DVT is feasible, general recommended treatment is duration is 3 months, PTS risk is high in iliofemoral DVT, and we can think about a risk reduction with the thrombus removal strategies. Thank you.
Nice presentation, Tom.
Thank you.
I know this is not a topic, but could you provide us an insight as to when you would consider giving anticoagulants in case of confluent superficial vein thrombosis?
Yeah, that's a good topic actually. According to the latest guideline, when a superficial venous thrombosis is there for more than 5 centimeter in length, and it is within 3 centimeter from deep junction, that is when it is having more than 5 centimeter in length and it is close to the junction with deep veins, we have to consider anticoagulate these patients. Trials were done using fondaparinux, but now recommendation is you can either give a fondaparinux or DAVACs in a reduced dose, that is 10 mg for 45 days. Suppose it is approaching very near to the deep system, there is high chance for it is to go into a proper DVT. So this patient needs formal anticoagulation, a full dose anticoagulation for 3 months. And also, usually it will be seen in varicose vein patient. So these patients should be anticoagulated, and any treatment should be done, like a venous ablation should be done after 3 months of giving anticoagulation.
Any more queries?
Thank you.
Thank you, sir. Thank you very much to all the chairpersons and speakers of the session. I think we come to the end of this session. Thank you, sir.